Okay, so in our final session before the lunch hour, I have the great pleasure of introducing Steve Landers, who leads the VNA Health Group in New Jersey. And Steve has the fortune and the misfortune to provide us with a vision of the future, talk about the ideal state coming up in the future, and really try and spur our thinking and really try and launch us for the remainder of the meeting. Steve.
Good morning. I think it's still morning, and quite an honor to get to talk to you this morning. I don't have slides. This is new for me. I do have my notes and what I intend to say. If any of it ever becomes of value, I've got some handouts of what I want to share. I got to be about the luckiest person in the world. I've been welcomed into my patients' homes thousands of times and been able to, learn about the richness of their lives and their challenges, and also work with great colleagues at Cleveland Clinic and Case Western Reserve on home care and post-acute care, and now with VNA Health Group, older, large nonprofit home care organization founded by over 100 years ago by Geraldine Thompson, who was actually supported in her efforts by her lifelong friend, Eleanor Roosevelt. And it's just the chance to be here with you today, just an incredible opportunity. I'm supposed to talk about the future. And, one of the thoughts that comes to mind is the advice of the famous physicist Niels Bohr that, prediction is difficult, especially when it's about the future. But I think that, for today, we should think that the future is really up to us. In my office, Ms. Thompson, our organization's founder, and her colleague Eleanor Roosevelt's picture is on the wall with Mrs. Roosevelt's quote that the future belongs to those who believe in the beauty of their dreams. And also, I'm reminded in the atrium of Cleveland Clinic, Dr. Toby Cosgrove's words painted on the wall that the future belongs to those that seize the opportunities created by innovation. So I think that this workshop and our work together in the weeks and months that follow is about dreaming a more beautiful dream for home health care, and also about seizing innovation opportunities. The time, this is important. We have over 70 million aging baby boomers that's been pointed out, as well as many other older and disabled Americans, people with disabilities, that are already experiencing unnecessary suffering and unnecessary expenses. I view this in many respects that we're at a Sputnik-like moment for home health care, so that we have an important task ahead of us. And I want to get into the future in some predictions and suggestions, but I don't want to forget about the important aspects of the past. I believe some of these may be opinion or experiential, but I think that there are some things that are true about home care today as they were when Lillian Wald ventured out of the Henry house on Henry Street into the Lower East Side at the turn of the 19th century. When we take care of patients at home, we get an enhanced view of basic things like their medications, their nutrition. It is an access intervention, bringing care home, that means most to people that have physical and socioeconomic barriers to care. Care at home can be more intimate. A more intimate clinician-patient relationship can be formed, sitting next to someone at the bedside, across from them at their kitchen table. It's an act of humility. It says, I cared enough about you to leave my comfort zone to see you in your home. It shows the person that they're worth being truly known and visited. Home care can, and this has been discussed in many different ways already this morning, it can cost less. And there's a strong body of evidence in the medical public health literature of certain models of home care for certain populations that cost certain payers less. Home care can cost less, and it's often desired more, and it can be safer. And Dr. Leff at the front of the room, has contributed incredibly to the world of home care research, and one of the more impressive findings has been that common complications of hospitalization can be reduced when care is moved home, such as delirium. Care at home can be safer. I believe that the future of home care is vibrant and impactful, that a wide range of services and support become commonplace in the home setting. In fact, Home care and health services may become so synonymous that we don't call it home care. It may just be called modern health care. Home-centered care is the person-centered notion that people with serious and disabling conditions can have access to holistic, sophisticated, and individualized care at home. I believe that home-centered care will continue its emergence as a major national health strategy for addressing undue suffering and undue spending among a variety of populations in the Medicare program and in our other public health programs. Now, this is going to be a bit different in Wichita than it is in Washington. It's going to be different in Asbury Park than Albuquerque and Akron, right? This is in true American fashion. This is going to be different in different places. But I believe that the organizers and purchasers of care will adopt home-centered care as a core strategy for meeting their needs. Again, these organizers and purchasers of care may be families, businesses, health systems, hopefully widespread independence at home programs, patient-centered medical homes, advanced illness care models, managed care organizations that integrate Medicare and Medicaid in some geographies, a wide variety of purchasers and organizers of care. One of our opportunities today is to accelerate the adoption of home-centered health strategies to meet our nation's healthcare needs. With respect to the Medicare program, I believe that the current and future role of Medicare home care services is fairly clear. It's to support the improvement of clinical outcomes, patient experience, and value in two core but often overlapping populations: post-acute care and care for the high-risk chronically ill. Said differently, the mission of home care services within Medicare will be to help beneficiaries safely and quickly transition home from hospitals and facilities to be able to continue their rehabilitation and recovery at home. And secondly, the mission is to support high-risk beneficiaries being able to age in place through providing certain primary medical care services and being able to intermittently escalate services at home at times of deterioration, decline, exacerbation. This includes supports in the last 6 to 12 months of life for that population. I believe that the emergence of home-centered care strategies will lead to great improvements in post-acute outcomes. We will see a dramatic change in the number of patients that go home as their initial first post-acute destination. And in the next decade, we should be able to have the proportion, the length of stay in post-acute facilities because of substitutive home health care. I believe that the patient experience and the family experience for people coming home from the hospital will be greatly improved by better information exchange, by more urgent and intensive initiation of home care, and by better mobile and digital resources. I think people transitioning home from hospitals and facilities should be at least as empowered as United Airline customers are with their apps in terms of updates and information about their care. Transitional models that include bridging interventions that help people move from hospital to home in a safe fashion will become widespread for many diagnoses, irrespective of people's homebound status or eligibility for current programs and current participations. This will drive reductions in early readmissions across many different diagnoses. For the highest risk chronically ill populations, I believe independence at home programs, enlightened patient-centered medical home concepts, advanced illness care models will work with home health agencies and other community resources to drive dramatic reductions in the number of nursing facility and hospital days per 1,000 beneficiaries, especially those 85 and older. They will drive improvements in key outcomes of care for this population, like unmet basic care needs, caregiver burden. I think one of the questions was, how do we address or assess the impact on caregivers? Well, in our current data sets in the Medicare program for home health or for facility-based care, there is not a measure of caregiver outcomes. We need to have some in order to at least hint at that aspect of care. I think that we'll be able to elevate the overall experience for the high-risk chronically ill by improved access, multi-channel touch points to the home, be they through the front door or through other devices, the telephone, video conferencing, what have you. And I think that we can lead over the next decade a doubling of the proportion of Medicare beneficiaries 85 and older that die at home as opposed to in facilities or intensive care units. These home deaths in the future will far outpace facility-based deaths in these populations. I believe that the unstoppable home-centered care movement It will drive these outcomes. Now, I think it's going to be quite a bit different in different places. But I think that meaning the cooks in the kitchen are going to be a bit different. But I think that the main ingredients are roughly the same. Main ingredient number one, physician and advanced practice nurse-led holistic interdisciplinary team care plans. Care plans that are driven by evidence-based geriatric medicine, palliative medicine, and rehabilitation medicine assessment concepts. Main ingredient number two, enhanced supports around care transitions. These include additional care coordination, better information exchange, and capacity for clinical stabilization. Main ingredient number three will be enhanced capacity for escalation of care at home in times of exacerbation and decline, including hospital at home-like services. Main ingredient number four will be the thoughtful use of new information technology to fill the white space in between our encounters, to provide better access and experience in between our visits, and to help us better triage our resources. These ingredients will be adopted and used by all sorts of purchasers and organizers of care throughout the country, and it will be different in different places. Accountable care organizations, bundle conveners, managed care organizations, advanced illness care models, independence at home programs. It will even be used by fee-for-service providers that are more sensitive to value-based adjustments in their fee-for-service payments. Now, I want to talk a little bit more what I think is the most important issue about whether or not we achieve the possibilities of home-centered care now in the next decade versus 2 or 3. And that's the situation with our Medicare certified home health agencies. These groups of nurses and therapists and other clinicians and paraprofessionals, they exist throughout virtually every community in the country. They have hundreds of thousands of staff, make millions, over hundreds of millions of home visits each year. They have immense local practical knowledge, and they also have incredible local relationships in terms of business and other clinical relationships with the people around them. They have a capacity for information collection for financial and quality monitoring. They also have a capacity, they have a licensure and accreditation framework, although flawed. They also have a payment model that is imperfect, but it does provide for the availability of these services in virtually every community in the country. I believe that the home-centered care movement is dependent on the function of this home health agency sector. In the future, the home health agency will be that paraprofessional team, that nurse, therapy, social work, and caregiving team that can support those interdisciplinary care plans that are developed by a wide variety of physician and advanced practice nurse-led care models and a variety of payment models. Said differently, the home health agency of 2024 may be a lot like the hospital of a past era. As we know, nurse, social work, therapy, and other services are essential to carrying out hospital care services in times of need for exacerbation or escalation of care at home. I believe the home health agency of the future will be that responsive team. I've seen with my own eyes how these clinicians can rise up and be this hub. But whether or not this happens depends on what we do now. It depends on whether or not we take steps to strengthen and improve our home health agency resources, or whether or not we allow it to be disintegrated, diminished, or cut indiscriminately. I believe that the future home health agency, Medicare certified home health agency, their payments are tied closely to outcomes and patient experience, and they're also tied closely to participation in a wide range of alternative payment models. These value-based changes in their payments improve the culture of quality and value in the Medicare home health sector. I believe the Medicare home health agency of the future has official medical directors that participate in interdisciplinary team care planning, much like we see in hospice care at the present time. These medical directors also help to rationally link and liaison home health agencies to these other physician-led and advanced practice nurse-led care models that are evolving throughout our country. I believe that the home health agency of the future is able to learn from the current Section 3026 Community-Based Care Transitions Demonstration Program and widely scale evidence-based care transition concepts to every corner of this country to help reduce readmissions, irrespective of whether or not the patients are homebound. And the Medicare Home Health Agency of the future works to dramatically improve the patient experience of post-acute and high-risk chronically ill beneficiaries through better use of information technology, information exchange. A decade of career training and advancement opportunities of home health agency staff in geriatric medicine, palliative medicine, and rehabilitation medicine care concepts greatly improve the home health agency sector's ability to meet this opportunity. The central role of home health agencies will also be catalyzed by making concerns about major fraud and abuse in the home health agency sector a thing of the past. Home health agencies will be accredited, not just at the time of licensure, but on an ongoing basis. Home health agencies will have public reporting of key utilization measures, such as episode per beneficiary, proportion of community-based admissions, proportion of low utilization payments that could be indicators of misuse or abuse, and value-based purchasing and other options, other policy options will be used to reduce the variation in these utilization measures. In geographies where there's outrageously aberrant utilization patterns compared with other parts of the country, there will be moratoria and even competitive capability-based RFPs to reduce the number of home health agencies in these geographies. The Home Health Agency of 2024 is a skilled and serious clinical organization capable of working with physicians in advanced practice nurse-led care models and new payment models in improving cost and quality issues in Medicare. I believe even beyond eliminating truly nefarious schemes which exist, that there will be much less of a role for unserious entrepreneurs that do not have the clinical resources or internal controls to avoid clumsily abusing the benefits. Although I work in the nonprofit sector and I'm an advocate for nonprofit services, I believe that serious and sophisticated for-profit enterprises will be an important part of building this future. Their investors and leaders will know that their profitability depends first on clear and unambiguous value creation for post-acute and high-risk chronically ill individuals. These for-profit companies will reach new heights because of their resources in talent, technology, and clinical resources that are focused on targeted clinical success. Today we have a big responsibility, an opportunity to catalyze the development, continued development of a home-centered healthcare system that can help improve value, help improve experience and quality for older Americans at the forefront of a major demographic shift. I believe that this future is right before us if we take the right steps. We know the main ingredients: holistic physician and advanced practice nurse-led care plans, support during care transitions, better information exchange, a variety of alternative payment models, reducing fraud and abuse, a high-functioning, high-integrity, well-supported Medicare Home Health Agency sector. In the coming hours and days, we're going to discuss a number of different models and concepts. And I'd ask that let's not focus on the names or the labels. And let's avoid the trap of trying to pick winners and losers among marginally different concepts whose success is based on local execution in many instances more than the name or label. And let's focus on broad themes and resources that can elevate home-centered care. I believe that the home-centered care future is tangibly before us if we just embrace and grow the seeds of change that have already been planted, and we work to improve, not diminish, our existing home care resources. I think we can make a big difference together, and thank you for the chance to address you this morning.